Hi, Dr. Doug Wyland from the Stebbin Hawkins Clinic. We're going to talk today about ankle problems, specifically cartilage problems in the ankle. Let me go through some basic anatomy of the ankle. The ankle joint is made up of the tibia bone and the talus bone. The ankle joint is what moves back and forth that allows your ankle to go up and down. Cartilage is the substance that covers the surface of the bone. There's cartilage that covers the talus bone and also this surface of the ankle called the tibial plafond. You can see when I turn the model to the side how the ankle moves. The actual weight-bearing area of the joint is fairly small. It's about 1 inch square. It withstands most of your body's weight with every step. If a person has an injury to their cartilage, you can understand how it could be quite disabling and painful. When a person has an injury of their cartilage, they'll present with pain and ankle swelling. They'll come into the office and say, something doesn't feel quite right. It hurts, it swells, and it gives way sometimes. Sometimes the history will be that the person jumped from a rock, or they turned their ankle the wrong way, or maybe 20 years ago they had an awkward injury. In any event, we'll make the diagnosis of a probable cartilage injury or a bone cartilage injury called an osteochondral injury, oftentimes based on the history and the evaluation. When we evaluate the patient, we'll have the patient go through a series of active range of motion activities to determine their range of motion and their strength. Most of the time, a person that has a cartilage problem will have pretty normal range of motion and they'll have pretty normal strength. Sometimes a person that has cartilage problems will also have an ankle that chronically gives way, and that's called ankle instability. Once we assess the ankle through our physical examination, we'll obtain radiographs. We like to obtain weight-bearing radiographs, so when you go to get your x-ray, they'll ask you to be standing up when you get your x-ray. We like to know what the alignment is of your ankle when you are standing, because if you do have a cartilage problem, we like to know where you're bearing most of your weight. If your heel's turned in when you stand, you could see that you'd bear too much weight on the inside of the ankle joint. And if your heel's turned the opposite direction, you could see you'll bear too much weight on the outside. And that's very important when we're determining where the cartilage problem is and how we're going to repair this problem. Once we go through the radiographs, as long as we determine that the alignment is normal, sometimes their ankle radiographs look perfectly normal. We'll obtain an MRI. An MRI study will help us to depict the cartilage lesion and diagnose if there's any problem with the underlying bone. Also, through an MRI, we'll be able to see the ligament structures on the outside and the tendons to see if there's any other problems around the ankle that could be causing the pain. Sometimes through an MRI, we can determine that there's a loose body, or we can sometimes see a spur a little bit better. Once we have all the information gathered, we'll sit back down with you and discuss what we think the likely problem is and our recommended solution. Unfortunately, for cartilage problems of the ankle, if it's a disabling and painful problem causing swelling, oftentimes surgery is the answer. There's different types of surgery to treat cartilage problems. I'll start with the simplest form, called arthroscopy. When we perform an arthroscopy of the ankle, we make small poke holes in the front of the ankle and then also one poke hole in the back of the ankle. We'll go into the joint and we'll be able to look at the surface of the cartilage. Through our preoperative planning, we will have figured out where the cartilage problem exists. It might be right here, for instance. Sometimes the cartilage lesion is about the size of a dime, sometimes smaller. Rarely is it bigger. We'll use a probe and we'll peel the cartilage back to see if the bone below the cartilage is healthy. As long as the bone below the cartilage is healthy, we can perform a procedure, which is really our first line of defense for cartilage lesions, called microfracture. Microfracture is a procedure where we use a sharp pick or sometimes a smooth pin, and we create tiny holes around the periphery of the lesion and in the central aspect of the lesion. And then we diminish the pressure within the joint and allow the bone to bleed up into the area. Think of that area as a little pothole, and think of the blood that's coming out into that area as pothole filler. It turns into fibrocartilage, which is very durable material. That, as you might imagine, it takes several weeks for the cartilage to mature and to become solid. Microfracture works very well as long as we have good cartilage all around the lesion. So for a very focused cartilage lesion, microfracture is our first line of defense. If a person undergoes a microfracture procedure, we can oftentimes do that arthroscopic through the small poke holes. The recovery is approximately 4 to 6 months, and the person will need to be non-weight bearing for anywhere from 4 to 8 weeks, depending upon the size of the lesion. During that course of non-weight bearing, we'll ask the person to place their ankle into a machine called a continuous passive motion machine. What we've learned is when cartilage is growing back into the area of the lesion, this continuous passive motion allows the cartilage to not only fill in properly at the proper level so it doesn't overgrow, but it also induces the cartilage to be a little bit more mature and a little bit more like the cartilage that you once had in that area. So the surgeon will ask you to place your ankle into this device called a continuous passive motion, or CPM machine, anywhere from 4 to 6 hours a day, which is a lot to ask, we understand, but the research is solid. Microfracture procedure is very successful. However, if the bone below the cartilage is not healthy, or if it has cystic changes in it, as we'll show you on the MRI, then we have to do a little bit more aggressive procedure. When the cartilage and the bone are both involved, that's called an osteochondral lesion. Osteo means bone and chondral means cartilage. And if the problem is chronic and on the MRI and by assessment reveals that there's fragmentation of the bone and cartilage, we'll call that problem osteochondritis dissecans. Again, osteochondral, bone and cartilage, and dissecans as in terms of desiccate. So that means that it's fragmenting or falling apart. And if you have that problem, that can be quite painful and disabling. It can produce loose bodies and a lot of inflammation and swelling. In that situation, we can't rely just on the bone to produce new cartilage. We actually have to go and obtain new bone. If the area, again, is about the size of a dime, perhaps 8 or 9 millimeters around, and as long as the person has a healthy knee joint, we'll go up to the knee and we'll obtain a core of osteochondral tissue from a healthy area of the knee. We'll drill out the area of the talus bone that's involved, and we'll place the new bone cartilage core into the lesion so that we have brand new cartilage and bone. And that heals quite well. It's predictably successful to relieve a person's pain. That's called osteochondral autograft if we obtain the graft from the person, or osteochondral allograft if we obtain the graft from a donor tissue. Usually we try not to obtain graft from a donor tissue unless the area involved is quite large. Most of the times we can do the microfracture and the osteochondral grafting through an arthroscopic technique with small incisions. Sometimes this requires larger incisions. Reason being is we have to be perpendicular to the surface of the joint. Analogous to opening up the hood of a car to get into the engine, sometimes we have to actually cut the bone to get into the ankle joint at the best angle. I'll show you again on the ankle model. If we have to cut the bone, first we pre-drill, cut the bone, and open it up. When we open up the ankle joint, it gives us a better direction to obtain fixation into the talus bone. Sometimes we'll cut the bone on the inside and sometimes on the outside. Again, those are called osteotomies. If that's done, the surgeon will repair this with screws, sometimes a plate, and usually this goes on to heal just fine. It's a little more involved, but if it's part of the process that gets the job done, that's what we'll do. Most of the time, bone cartilage problems can be handled with these joint restoration type procedures. Occasionally, a person will come in and they've sustained an injury to the ankle, and it will be an acute fracture. And the fracture won't be the standard ankle fracture, but instead will be an osteochondral fracture, oftentimes involving the talus bone. If that's the case, we repair the bone and the cartilage back, and we can oftentimes do that through arthroscopic techniques. When that injury occurs, again, we approach the problem arthroscopically through small poke holes. We enter into the ankle joint. We size up the lesion. We place the bone and the cartilage piece back where it belongs. And oftentimes we'll put small absorbable pins into the lesion to stabilize the fracture. And as you might imagine, if we can get it to fit just right and stabilize it, those go on to heal and do quite well. The treatment for an unstable fragment is just that, fixation. If the fragment is deemed to be stable, as we would determine by X-ray or MRI, then your doctor will simply ask you to be non-weight bearing for a period of time. In all of these cartilage lesions, oftentimes there's other collateral damage. Sometimes patients with cartilage lesions will have the lesion because the ankle gives way, and that's chronic instability. If a person has a combined problem, then we'll simply add ligament repair or reconstruction to the cartilage procedure. Most of the time in the course of treating cartilage lesions, we can expect a good outcome. We hope you've learned a lot about your cartilage problem and your ankle today, and hope you go on to have an excellent outcome.